Annyeonghaseyo. Hello students, bienvenido. Professor Scott here with our review on fluid and electrolytes and then the perioperative process. So getting right into this, I know we've been having a pretty good semester so far, so let's keep it up and we'll definitely get you some review here, get you prepared for the test. Just a little update. I tried recording a video over by the water and it was a little bit too windy. My papers and book blew into the water and they got all wet. So now I had to relocate. I'm deep inside the Whitnell Park forest here, and hopefully I won't run into anything too crazy out here. So one of the first things I want to talk about with fluid and electrolytes is the function of water in the body. And in class, I definitely made sure that we knew the four processes that water serves in the body. So one of the processes first is water is a vehicle for transportation of substances such as electrolytes, hormones, blood cells, waste products. So water is very important in moving solutes around the body. And of course we know whenever there's a backup of fluids or when the fluids aren't circulating as well, that can definitely lead to some problems. So another thing that water does is it serves to cool the body down. Now when you sweat, you know, sometimes you can sweat from being nervous or you sweat from exercise or being too hot. The process that sweat serves is to cool the body down. And so that is a key process there of water. One of the other things that water does is it helps balance out the hydrogen ions that are in the body. And remember that I said that hydrogen ions, when they build up, it can become a little toxic to the body. And then the other thing that water serves a purpose for is with digestion, the enzymatic action. And water is constantly going across the semi-permeable membranes in your intestines to help you digest your food, move the nutrients from the food to your body, and then also to help eliminate waste products. So one of the things that we talked about in class was how do we lose water? And when we're losing too much water and not replacing it with enough fluids, we can get dehydrated. And we know that dehydration is not good for the body, especially for our younger, our infants, and then of course the older adult. And when we say the older adult, we mean people aged 75 years and younger, or 75 years and older. So when I refer to the older adult, it's 75 and up. So when we lose fluids, we lose it through our urine. That is one of the major losses of fluid is when you pee. When you sweat, of course, you lose fluid and water when you have a bowel movement. And then, of course, when you exhale, when you're exhaling, you are letting out water vapors. So those are all key ways that water goes out of the body. And of course, like I said, if you lose too much water, you run the risk of being dehydrated. So when we're nauseous and vomiting, that is a way of losing water, and also acid. When you vomit, there's a lot of stomach acid mixed with that. So when you're vomiting, you're losing acid. And when you're losing acid, that can move the pH up towards alkalotic. And of course, the pH level that is normal is 7.35 to 7.45. When you're above 7.45, you're moving to an alkalotic state. When you're when your pH is dropping below 7.35, you're moving to an acidotic state. And that is important for understanding ABGs. And there are going to be some questions on the test that concern ABGs, being able to distinguish between respiratory acidosis, metabolic acidosis, respiratory alkalosis, and of course metabolic alkalosis. So I want to talk a little bit about how body fluids are distributed within the body. And remember in class I talked about 1/3 of your fluids are located extracellularly. And when I say extracellular, that means everything that's outside of the cell. So that includes interstitial fluid, intravascular fluid, which is in your veins, and then of course the intracellular fluids. That accounts for 2/3 of your fluids. So 66% of your fluids are located inside the cell, intracellularly. So that's important to know, because the composition of electrolytes tends to be a little different when you're looking intracellularly versus extracellularly. And I told you guys that extracellularly we tend to have a higher concentration of sodium. Intracellularly we tend to have a higher concentration of potassium. So when we're talking about fluids, how do fluids move within the body? Well, there's 4 processes that we talked about: diffusion, osmosis, filtration, and active transport. Now those first 3, diffusion, osmosis, filtration, they don't require any energy expenditure. So that means these fluids are moving within the body, and it doesn't require ATP. It doesn't require you to use energy. Now the one of those that does require you to use energy is active transport. And we have to expend a little bit of energy to move around the fluids and solutes when we talk about active transport. So moving on to the kidneys. What do the kidneys do? The kidneys, when I say kidney, that means also the renal system. And when we talk about healthy kidneys, what they do is they help filtrate the body. They help regulate fluid and electrolyte balance by reabsorbing sodium, potassium within the tubules of the kidneys. So when someone has kidney disease, renal failure, or renal disease, they are not able to regulate their fluid balance effectively. So what does that put them at risk for? Either they can become dehydrated, or they can end up with fluid overload. And when you have too much fluid in the body, that taxes the heart, that taxes the vascular system, so that can lead to high blood pressure. That's very important. Moving on, some of the signs and symptoms of dehydration I want to talk about. Of course, when you're dehydrated, you feel thirsty. When you're dehydrated, you have poor skin turgor. And remember, I talked about with the older adults, assessing skin turgor as a measure of dehydration in our older adults, 75 years and older, they start to lose the elasticity of their skin. So measuring skin turgor in the older adult is not an effective way of measuring dehydration. What we do want to look at in the older adult to assess for dehydration: dry mucous membranes, decreased urine output, maybe thick saliva, and then just general signs and symptoms of dehydration in everyone else, of course. We can look at the skin turgor for those who are age 75 years and younger. And what happens is when you're dehydrated, that skin turgor tends to tent. So when I pinch this and let it go, it'll stay tented for a little bit. It'll stay looking like it's pinched. Some of the other things, signs and symptoms of dehydration: dark concentrated urine. I already talked about dry mucous membranes. The eyeballs may look a little sunken in. They may have flat neck veins when they're laying down. They could have a weak weak, rapid, thready pulse. Temperature, when you're dehydrated, temperature can go up. Now, looking at the signs and symptoms of overhydration, that's when you have too much fluid on the body. You'll get weight gain, edema, third spacing. You will have hypertension, elevated blood pressure. You can have crackles in the lungs. Of course, when there's fluid overload, the fluid has to go somewhere, and it tends to either accumulate in dependent areas like your feet, your legs, and then it can also accumulate in the lungs. And when you accumulate fluid in the lungs, you're at risk for pneumonia. So what does that sound like when you're assessing? You'll hear crackles, diminished lung sounds possibly. They can also have, when you're overhydrated, the sodium levels get diluted. So someone who's overhydrated, they might have hyponatremia, low sodium. Now the opposite of that, like I said, with dehydration, when you don't have enough fluids, the sodium concentration levels tend to go up within the blood. So some of the interventions we want to do for our people who are dehydrated, we definitely want to encourage fluids. We try to give them fluids of their choice. We want to encourage them to drink fluids that they like, because then they're more likely to drink those fluids. We can administer IV fluids. And of course, in our older adults, when they're dehydrated, we don't want to rapidly infuse an IV. So you definitely want to go slow with the IV infusion on our older adults. One of the other things also that can lead to dehydration is, exercise, obviously, when you're sweating too much, when you're just losing too much fluids in general. So that can look like diarrhea. With diarrhea, you're losing too much fluids. If you're vomiting, you're losing fluids. Going on to our patients who have excess fluid volume. Some of the interventions that we want to do for those who have too much fluid is we tend to put them on a fluid restriction. We can administer diuretics. And whenever you're administering a diuretic, specifically Lasix, you want to know their potassium level. And the normal potassium level is 3.5 to 5.0. And when you're giving Lasix, it tends to cause you to excrete a lot of fluids through your urine. So for our people who have too much fluid on board, they have high blood pressure, we give them Lasix. That causes them to excrete the fluid. That helps drop the blood pressure, helps decrease the fluid volume excess. But the one thing with that, when we lose a lot of fluids like that, especially with Lasix, aka furosemide, we tend to lose potassium. So we definitely want to know our patient's potassium level before we administer Lasix. And a lot of times in my practice, most of the healthcare providers would prescribe a potassium supplement whenever they prescribed Lasix, furosemide. So that's important. Looking at going on with our electrolytes, of course, the normal electrolyte level for sodium is 135 to 145. Some of the symptoms when you have low sodium, it could be either that you're not taking in enough sodium, it could be that your kidneys aren't reabsorbing sodium like they should, or it could be that you have an excess of water because that dilutes your sodium level. And the average intake of sodium per day is usually 4 to 5 grams. Some of the signs and symptoms with sodium, when you have a low sodium level, it tends to result in fatigue, lethargy, and remember I talked in class that a lot of these things, when you have too high sodium, too low sodium, too high potassium, too low potassium, and then of course calcium, too much and too little. The signs and symptoms tend to look pretty similar. So we gotta try and pick and choose which of these signs and symptoms we can use to help us decide whether it can be too much or too little. So looking at calcium, the normal calcium level is 8.4 to 10.6. When there's some certain surgeries, when we look at the thyroid gland, whenever there is a surgery with the thyroid gland, there's the thyroid gland helps with regulation of calcium. So if someone was to have surgery on their thyroid gland, it's very possible that they could have an imbalance of calcium. So what are the signs, some of the signs and symptoms that we can look at with low calcium? We talked about the Trousseau sign. The Trousseau sign is where we put the blood pressure cuff on, we pump it up, and then their hand starts to do this this weird, what do they call it? The palmar flexion, carpopedal spasm. So you put the blood pressure cuff on, squeeze it up, their hand does this. That can be a great sign that they have too little calcium in their body. The other sign is when you tap on the area right here, they'll start having tetany. Tetany is like twitching a muscle spasm. So whenever someone has tetany, a positive Chavastic sign, that is this, and they're twitching, the positive Trousseau sign, that can be indicative that their calcium is too low. Another important thing here is whenever we're removing fluid from the body, like I said with urinating, if you put a nasogastric tube in someone and you remove a bunch of fluid from their stomach, that can cause an imbalance of their electrolytes also. Moving on here. We talked about that. Sorry, my paper's here. Like I said, my paper and my book went into the water. So all these papers are wet and they just look terrible. I'm a little distressed about it. Some of the things that with when you have too low potassium or too high potassium, when you have too low calcium or too high calcium, that can lead to cardiac dysrhythmias. That is why we definitely want to monitor our patients' potassium and calcium levels. When someone does have a low sodium level, like I said, it could be that they have too much fluid on board. One of the nursing interventions that we do is we definitely want to restrict their fluid intake, and I think I already talked about that. Moving on to blood cells. Within our blood cells, we got the red blood cells, hematocrit, hemoglobin. We got white blood cells. The normal white blood cell count is between 5,000 and 10,000. And when you're above 10,000 count on your white blood cells, that can be indicative of an infection. When someone has a low white blood cell count, that could indicate something along the lines of a cancer, possibly leukemia. So some of the interventions for our people who have below 5,000 white blood cell count, they are at risk for developing an infection. They're very susceptible to developing an infection. If you don't have enough white blood cells in your body to fight the infection, you are more likely to get it. And so we definitely want to know the normal count of our white blood cells, 5,000 to 10,000. When we look at platelets, I talked about platelets. Those help with blood clotting. So if you get like a cut or something, You want your platelets to aggregate to that area so that you won't lose too much blood. And so one of the things, when you have a low platelet count, someone who's got low platelets, and the normal platelet was about 200,000 to 400,000. So anytime you're below 150,000 platelets, there's definitely some interventions that you want to be doing. You want to be teaching your clients to avoid high impact exercises. You want to tell them to not use razors. You do not want them to use a razor. They can use an electric razor for our people with low platelet counts, but you don't want them using a sharp razor that could cut their skin, because then they could lose too much blood. One of the other things that you want to do is definitely, for people with low platelet counts, teach them to use a soft bristled toothbrush versus a hard bristled toothbrush. And with the hard bristled toothbrush, what you can do is when you're brushing, you can actually cause your gums to start bleeding. So you want to teach our clients to use a soft bristled toothbrush, use that electric razor. We also want to teach them to be safe, to avoid falls. And one of the ways that we try to help people avoid falls, of course, is we tell them to use their Coagulate. We make sure that their bed is in the low position, that the Coagulate is within reach. We want them using non-skid shoes or socks when they're walking. We don't want them walking around barefoot around loose throw rugs, because if someone who has a low platelet count falls, they can basically bleed internally. And then also with our, talking a little bit about our PT-INR, we definitely, people who need to thin their blood typically have AFib, atrial fibrillation. They might have a mitral valve replacement. So the doctor puts them on warfarin, Coumadin. And one of the ways that we monitor the effectiveness of Coumadin is to look at the PT-INR. And the INR typically is about 0.8 to 1.2. To be at a therapeutic level where we thin the blood so that they don't get a clot, we want that from about 2.5 to 3 times the normal INR. So what that looks like, someone who's on Coumadin, you want them to be at an INR of about between 2.5 to 3. And if you're below 2.5, it's not at a therapeutic level. When you're above 3.0 on the INR, they have the potential to bleed. So one of the things with platelets and Coumadin, someone who has low platelets, we want to encourage them to intake green leafy vegetables. However, someone who is on Coumadin, we teach them to avoid green leafy vegetables, because green leafy vegetables contain vitamin K. And remember, vitamin K is the antidote to Coumadin overdose. So vitamin K actually helps with clotting factors. So for our people who have low platelets, we want them to have clotting factors. So we encourage green leafy vegetables. Versus the people who are on Coumadin, we want their blood thin so they don't develop a clot. We teach them to avoid green leafy vegetables. Moving on here, we're going to be getting into the perioperative soon. Oh, we got to go over our ABGs real quick. So when we're looking at someone who has a low pH below 7.35, the first thing we look at is we determine the pH level. And if the pH level is below 7.35, we consider that acidotic. If they're above 7.45, we consider that alkalotic. The next thing that we look at is the PaCO2, and that is a measure, the normal is 35 to 45. So someone who is in respiratory, and PaCO2 has to do with the respiratory. And when we look at that, someone who has a low pH, they're acidotic, they have a high PaCO2 above 45, we know that that's respiratory acidosis. And sometimes respiratory acidosis can present as someone who may have overdosed on opiates. So they're not they're not able to excrete CO2 when they exhale. So what that looks like is they'll have slow respirations, there'll be shallow respirations, and their pulse ox may be low because they're not adequately ventilating themselves. They're not blowing off the CO2, and CO2 is an acid, so when that CO2 builds up in their body, they become acidotic. Now, when we look at some of the interventions for somebody who is in that state of respiratory acidosis, we definitely want to have oxygen readily available. We want to try and encourage them to open up their lungs. So that's about that with respiratory acidosis. When we look at alkalosis, the pH is above 7.45. When we look at HCO3, remember I taught you in class that HCO3 coordinates with bicarbonate, the buffer. That is what is the buffers are utilized in your body to help counteract acids. So for someone who has lost too much acid, someone who's vomiting, they're puking, they're throwing up their stomach acid, that is someone who is at risk for developing alkalosis. And they may have an excess of bicarbonate. So the bicarb would be above 26. Normal levels of HCO3, aka bicarb buffer, 22 to 26. When you're below 22, you don't have enough bicarb. So that can either be because you have too much acid or you have a loss of bicarbs. When there's too much when the HCO3 is above 26, it can be that you have an imbalance of too little acid. So when you're throwing up acid, that puts you at risk for metabolic alkalosis. All right, getting into the perioperative part here now. That was chapters 4 and 5. We definitely, when I talk about perioperative, that means preoperative, intraoperative, and postoperative. And preoperative, the first thing that we want to do already, especially with people who have planned surgeries, we want to start teaching them what to expect for after the surgery. So preoperative teaching includes what they should expect after the surgery. So that may be their therapy schedule, the medications they're going to be taking. Are they going to be experiencing pain? How should they be treating the surgical wound that they get? Because when we're in the hospital, we're using aseptic technique. When we're teaching our clients to change their dressings at home, we're teaching them the clean technique. So we always, encourage them to wash their hands. Don't be picking at the wound. Keep dirty stuff out of that wound. That is all very, very important stuff. So preoperative, we definitely want to look at what medications they're on. And if somebody comes in on a medication, and also their supplements, what supplements they're on. Someone who's on a corticosteroid, if they're on a corticosteroid before surgery, we need to let the physician know, because corticosteroids can actually increase your risk for infection because it raises your blood sugar. The more sugar that's in your blood, you definitely have more of a chance of developing an infection. So we want to know what medications they're on. Do they smoke? Do they drink? What is their lifestyle like? We need to know these things before they go into surgery. And of course, before surgery, we want them to be clean. So we teach them to, sometimes we give them special baths, like a CHG bath, to help kill all that bacteria. Because when we cut their skin, we don't want bacteria on their skin, because that can creep into that surgical site and cause an infection. So what else do we want to talk about with preoperative? I talked about how sometimes people like to store their blood, the autologous blood for transfusion. They store their own blood in case they need a blood transfusion, because some of the risks with any surgery is they can develop infection and they can lose too much blood. So going on, intraoperatively, of course, they're getting a lot of medications. The doctors tend to use general anesthesia or a local anesthesia. General anesthesia is where they put the whole body to sleep. And sometimes there's clients who, like our elderly clients who can't tolerate general anesthesia, so then we use a local anesthesia or a spinal anesthesia, and that will just numb a certain part of their body versus general, which puts the whole body to sleep. Now when they're coming out of surgery, they go to the PACU. In the PACU, they monitor them. The first thing they're always looking at is their airway. Remember our ABCs: airway, breathing, circulation. Those are our top priorities when they go to the PACU. And even when they go to the PACU to your unit, the first thing you always want to be assessing is their airway. And if they don't have a patent airway, if they're having trouble breathing, or it looks like they have a circulation problem, we definitely want to let the doctors know right away. That's always a high priority is the ABCs. Postoperatively, some of our clients may be put on bed rest. So with our clients who are on bed rest, we definitely want to encourage them to be doing leg exercises. We're doing range of motion on them, because when you're on bed rest like that, it can lead to a deep vein thrombosis or a clot that goes to their leg or somewhere else in their body. So we definitely want to be looking out for that. And what are the signs and symptoms of someone who has a DVT, a clot in their leg? That leg or calf might become red, swollen, painful. You never want to massage their legs if they tell you that they have those symptoms, because you can dislodge the clot. If the clot gets dislodged in their leg, it can travel to their lungs or heart, and then we're in big trouble. Postoperatively, some of our patients, it's a little slow for their body to wake up because of the anesthesia. However, we want our patients voiding, we want them peeing within 6 to 8 hours after surgery. So if someone is not peeing beyond 8 hours, we definitely want to call the healthcare provider and let them know, hey, this client isn't peeing. That can be a problem. Moving on here. Someone who has had surgery, and sometimes they're losing blood from their vascular system, and it's going into their body cavity. So you may not, someone who's losing blood from their vascular system, you may not see actual blood coming out of the body, but what can happen is the blood pools inside the body. And one of the things that, a sign and symptom that they're losing blood or they're hemorrhaging, is their blood pressure drops. So we definitely want to be monitoring vital signs, blood pressure, respiration, all that good stuff. Of course, signs and symptoms of infection, I think we talked about that. Was that in the last test? Or, oh no, maybe we talked about this. So signs and symptoms of infection, they'll have a high temperature. Signs and symptoms of an infection will be increased redness, increased tenderness, purulent drainage at the surgical site. If their white blood cell count is above 10,000, so 11,000, 12,000, 13,000, that can be a sign that they're developing an infection. And then postoperatively, we want them to open up their lungs. So we teach them to do coughing and deep breathing. Our people who've had abdominal surgery, we teach them to use the pillow to splint with. They put that pillow against their incision in their abdomen, and then they can cough and deep breathe. We're encouraging them to do hourly incentive spirometry. That helps prevent atelectasis. Atelectasis, remember, is where the alveoli are collapsed, so then there's not adequate circulation fluids can accumulate in those spaces, and that can lead to pneumonia. Oh, sorry, I forgot to talk about preoperatively. Preoperatively, the doctor is the one that will be going over the surgery with the patient, informing them of what to expect. So when we talk about getting that consent form signed, we have to make sure that before the patient signs that consent form, they are well informed and able to make a decision that they want this surgery. And at any time, the patient has the right to withdraw consent. So that's a big patient right, is to be able to withdraw that consent. At any time, the patient can say, hey, I don't want this surgery anymore. Even if they've signed the consent, they're down in surgery and the doctor is ready to give them, or the nurse is ready to give them their preoperative meds. Before we give those preoperative meds, we have to make sure the consent form is signed. And then even after they sign that consent form, the patient still has the right to withdraw his consent to that surgery. So I think that's about it. Of course, our patients, post-operatively, we want them moving around as soon as possible, as long as it's not contraindicated. Sometimes the doctor will say, I want strict bed rest. In all other cases, we want them moving around as soon as possible, as long as it's safe. We want their fluids moving around. We want them breathing. We want them opening up their lungs. Of course, for our older clients, we want to, when we're talking about a surgery for our older clients, we want them well informed, and we want to give them plenty of time to process everything that we've told them. And as nurses, as healthcare providers, the doctors, the healthcare providers, sometimes they can be a little rushed, and they start just, in routine, they spit out the surgery because they've said it a million times. So sometimes they kind of rush through the surgery. For our older adult population, we definitely want to give them time to process everything we're saying to them. So we speak slowly to them. We help them process, what's going to happen with the surgery. So we definitely want to give them enough time to be able to make a decision. And then for our confused patients who have dementia, we definitely want the family in the room or their healthcare provider in the room, so that they can help make the decision for them. But just because you're old doesn't mean that you can't make your own decisions. Also know that for wound healing, our diabetics are people who are at risk for developing complications after surgery. Specifically, our diabetics, they have delayed wound healing. So there can be complications that come about with our diabetic patients who have surgery. And one of the things to encourage wound healing, we know that vitamin C is a great vitamin that helps with wound healing. So that's very important to know. So encouraging, foods that are high in vitamin C, like oranges, citrus fruits, those all help with wound healing, and having adequate nutrition, of course. So someone who has, going back a little bit to our hypercalcemia, someone who has too much calcium in the body, they are definitely at risk for developing renal calculi. And those are the kidney stones. Those are very painful. So someone who has a high calcium level, they are definitely at risk for renal calculi. So, all right, I think that's about it. I hope this was helpful. Make sure you guys are studying, reading chapters 3, 4, and 5, looking at those key points, using the study guide. You want to be doing the NCLEX questions. So I really hope this was helpful. It looks like we're getting to about 40 minutes here, so that's about, I think, the max that we can do for this. But really hope this was helpful. Make sure you're studying, and I guess we will see you next week with our unit test 2. That's on fluid and electrolytes and the perioperative. So that's chapters 3, 4, and 5. Definitely think everyone's doing great this semester. I'm so proud of everyone for coming to class on time, participating in class, using your focus, and our Qigong breathing exercises. I really am so happy that everyone's been so open to doing these Qigong breathing exercises, because it's really important to understand the process that oxygen plays in our body, and then also to have a tool that we can use to help increase our focus, increase our circulation, and increase our health. So definitely going to be doing some Qigong breathing exercises before the test next week. So awesome. Thank you guys so much. Annyeonghaseyo. We'll see you next